Hi, in this in a nutshell module, we're going to look at arterial blood gases. And what we're going to try and do is look at a couple of common clinical conditions: anemia, polycythemia, low inspired PIO2, increases in 2,3 BPG, increased arterial PaCO2, which I hope you remember to think of as hypoventilation, fever, carbon monoxide poisoning, and methemoglobinemia, and try and figure out how they'll affect arterial partial pressure of oxygen, arterial content of oxygen, and arterial saturation of oxygen. And so just to start out, I think, again, it helps to think about independent variables, that is, ones that are determiners, and that would be the partial pressure of oxygen, and then determined values, and that would be content and saturation, which are determined in part by the partial pressure of O2 when we look at this. So just to remind you, the partial pressure of O2 expresses the amount of oxygen that is dissolved in blood. It has nothing to do, and it's independent of the amount of hemoglobin or the P50 of hemoglobin, and depends on alveolar air and the AA difference. Oxygen content is the total amount of oxygen in blood, and it does depend to a large extent on hemoglobin, because primarily hemoglobin is the way oxygen is carried in blood. And just reminding you to get ready for the oxygen dissociation curve, we talk about oxygen carrying capacity as the oxygen content when we're on the plateau portion of the oxyhemoglobin dissociation curve. And then the last one we're going to talk about is oxygen saturation, and that basically expresses in relative terms the oxygen content that is there. You can think of it as the fraction of binding sites that are occupied by on hemoglobin that are occupied by oxygen at any given time. So it's essentially the oxygen content divided by the oxygen carrying capacity, which is the oxygen content at the plateau of the dissociation curve. So really it helps to look at our independent variable here, the arterial P(a)O2, the arterial oxygen, which we're measuring over here in the aorta or the large arteries, as being dependent on only two things: the P(A)O2, that is, how much oxygen is in the alveolar air, because that's where it's coming from, so it represents the best it can be, or an upper limit, if you will, and the AA difference, which measures how efficiently the gas exchange surfaces are working. So you'll get an AA difference if the gas exchange surfaces aren't working well, and by that we mean largely VQ mismatching, right to left shunt, and diffusion abnormalities. So just thinking about P(A)O2 again, we remember that it's PiO2 minus PaCO2 over R, where this is sort of the amount of oxygen you took out and burned up, and this is the amount of oxygen you started out with. Therefore, the PaO2, P(A)O2, is what's available in alveolar air to get into arterial blood. So let's look at the PiO2 term again. That was Pb minus 47, an expression for dry barometric pressure, and FiO2, the fraction of the dry air that contains oxygen. So if we look at this all together, P(A)O2 depends on several things. Barometric pressure, which really goes down when you go to altitude, is the main way you see a decrease in that. FiO2, which goes down if you suffocate, which is the main way you see a decrease in that. And an increase in CO2, which is caused by hypoventilation. So hypoventilation, altitude, and suffocation all decrease P(A)O2, which in turn will decrease P(a)O2. And then the AA difference, we already said, was VQ mismatching, right to left shunt, and diffusion abnormalities. So these are the 6 things, 3 here and 3 here, that can affect P(a)O2. Notice that hemoglobin's concentration and affinity do not affect the partial pressure of oxygen in arterial blood. So we're going to start by going down our independent variable here, P little AO2, and looking at each of these conditions in terms of the three things that can affect P big AO2 and the three things that can affect the AA difference, and go through them with our checkbox. So looking first at anemia, anemia doesn't affect the altitude, doesn't affect cause hypoventilation, doesn't affect cause us to suffocate, and it doesn't affect any of these three things. So in the end of the day, P little AO2 is not affected by anemia. Similarly, in polycythemia, we see no change in altitude, suffocation, or hypoventilation, and no change in VQ mismatching, right to left shunt, or diffusion abnormality. So again, we have no change in P little AO2 in polycythemia. The third one, low inspired PIO2, where you remember that that is PB minus 47 times FiO2 here, can go down in two ways. There's two ways to get a decrease in PiO2. One is to go to altitude, which will decrease the barometric pressure, or the other is to suffocate, which will decrease the FiO2. And so we're talking about a decrease in this term, and obviously if that term decreases, P big AO2 will decrease, and therefore P little AO2 will decrease. So low inspired oxygen, a decrease in P little AO2. So if PiO2 decreases, P little AO2 decreases. The next one is an increase in 2,3-BPG, we call it nowadays. And what that does is shift the oxyhemoglobin dissociation curve to the right, but it doesn't change the altitude we're at. It doesn't cause the FiO2 to change, and we don't hypoventilate, nor do we get changes in VQ mismatching, right to left shunt, or diffusion abnormality. And so the bottom line is we have no change in P little AO2 when we have an increase in 2,3-BPG. Next, we have increased arterial PaCO2, and again, I hope you translate this immediately to hypoventilation. And if you look at our curve here, we see immediately that increasing CO2 causes it to subtract a bigger number from PiO2, this whole set of terms here, and so P little big AO2 falls, and therefore P little AO2 falls. But there's not much change in VQ mismatching, right to left shunt, or diffusion abnormality, just as expressed here. And so the effect of hypoventilation ultimately is to decrease P little AO2. Fever. Again, fever is going to shift the curve to the right, but it's not going to affect altitude, suffocation, hypoventilation, VQ mismatching, right to left shunt, or diffusion abnormality. And so what happens to P little AO2 is virtually nothing. Okay, coming on down, carbon monoxide will be our next one. And again, no change in barometric pressure, FiO2 or PaCO2, no change in VQ mismatching, right to left shunt, diffusion abnormality, and therefore no change in P little AO2 in carbon monoxide poisoning. And I just bet you can guess methemoglobinemia doesn't affect any of these six things, and so once again, it doesn't affect the P little AO2. And so this is our list, and only two of them affected P little AO2, which depends just on P big AO2 and the AA difference. Now we're going to look at our two dependent variables, content and saturation of oxygen, in the context of what happened to P little AO2, and think about where we're going to be in these sorts of situations. So the first thing we need to do is look at the coupling between the independent variable and the dependent variable, and that's done through the dissociation curve. So we have a sigmoid dissociation curve relating content to partial pressure or relating saturation to partial pressure. But the other thing we have to do is decide where on this curve we're looking. And we're looking at an arterial blood gas, and so we need an arterial PIO2 to think about. And the way we get that is by knowing that sort of a typical alveolar oxygen is 100 millimeters of mercury, and a typical AA difference is about 5 millimeters of mercury if you're really, really healthy. And so arterial PO2 of 95 is a really reasonable value to look at to figure out where on the oxygen dissociation curve we should be operating when we take an arterial blood gas value. And so we're going to look at 95 as sort of the textbook value for our oxygen dissociation curve. So then, looking at anemia and polycythemia, a loss of red cells and therefore a loss of hemoglobin, or an increase in red cells and therefore an increase in hemoglobin, we can look at a normal oxygen dissociation curve here in black, and we can see that if we become anemic, our hemoglobin drops from 15 to 10 as shown here. We'll move down to a lower plateau, and if our hemoglobin increases from 15 to 20, we'll move to a higher plateau. And so you can immediately see that at our arterial blood gas value, we increase the oxygen content in polycythemia, and we decrease the oxygen content in anemia. But what about saturation? Saturation represents the percent of the binding sites that are occupied with hemoglobin. And we have a normal amount of binding sites, more binding sites, less binding sites, but the percentage of the binding sites just depends on where are we on the oxygen dissociation curve. And in all three cases, we're on the plateau, so the saturation is about 97 or 98% when we're on the plateau portion of the curve. And so when you plot saturation as a function of partial pressure, we see that anemia, polycythemia, and normal curve all lie essentially on top of each other, and they all have essentially the same 97 or 98% saturation. So although content goes up in polycythemia and down in anemia, there's relatively little change in saturation with either anemia or polycythemia. So next we wanted to look at low inspired PIO2, and basically that means that the vertical red line that we're looking at here is going to move to the left, and in this case I show it at critical PO2 of about 60 millimeters of mercury. And what you can see is we move from the content that we have in normal blood, shown by the black dot, to the content we have in a low PIO2, the blue dot. So we see a decrease in content, and likewise we see a decrease in saturation from the black dot to the blue dot. Next we have 2,3-BPG, and again we remember that principally what that does is shift the curve to the right, and so we need to draw a right-shifted oxygen dissociation curve, which we do in blue here. And when we look at our arterial value, what we see is that the blue dot and the black dot are practically on top of each other because we're on the plateau of the dissociation curve, whether we're plotting saturation or content. And these are going to be clinically indistinguishable from each other, the black and the blue dot, in either of these circumstances. So we're going to say no change or negligible change in content and saturation when we have an increase in 2,3-BPG. Next up is an increase in arterial CO2, and you'll remember, like 2,3-BPG, that right shifts the curve. And so we're going to get this right shifted curve. But the important thing here is that an increase in arterial CO2 is what? It's hypoventilation, and so it decreases P big AO2 as well. And so now we need to look at this vertical line that is drawn to the left of the normal 95 millimeters of mercury, which gives us this blue dot, where you can see clearly that the content is less than the content with the black dot, and likewise the saturation is less. And so what we see is we get a decrease in content and saturation when we have an increase in CO2, aka we're hypoventilating. Next will be fever, and again fever right shifts the curve, but like 2,3 BPG, we are still at a normal arterial blood gas value, and we won't be able to distinguish content or saturation from the blue dot and the black dot, which are both sitting on the plateau of their respective curves. And so fever causes negligible change in content or saturation. Then our next one is carbon monoxide poisoning, and I'm going to just look for these last two at content to start with. And what we see is that in carbon monoxide poisoning, carbon monoxide binds about 210 times as well as oxygen, and that causes a shift in the oxyhemoglobin dissociation curve, which results in the plateau being at a lower level. It's a functional anemia, if you will, as well as decreasing the P50, which has to do with changes in cooperativity. But clearly, very clearly, we have a decrease in oxygen content when carbon monoxide is on board compared to the normal value shown by black dot there. And very similarly with methemoglobinemia, we have a decrease in the plateau level of the curve over normal. But this time, because it turns into ferric iron, Fe3+, which won't bind to oxygen, and so basically we have a functional anemia due to methemoglobinemia, and so we get a decrease in oxygen content. So how about saturations? And these are a little bit odd because people don't usually talk about saturation in methemoglobinemia and carboxyhemoglobinemia. But I want to talk a little bit about it in the context of pulse oxes, which are ubiquitous now, and we make measurements all the time just to give you an idea of, can you see carboxyhemoglobinemia or methemoglobinemia if you put a pulse ox on a patient. And the way these things work is they measure absorbance at two different wavelengths of reddish light, and they translate the relative absorbance at an isoaspestic wavelength, where the absorbance is similar to a second wavelength, into a measurement that gives the fraction of hemoglobin that is bound to oxygen, i.e. a pulse ox sat. And they do this by looking at the surge of arterial blood into the capillary. So they're sort of looking at capillary blood, but as it surges in, they take the measurement just after the arterial blood comes in and before it's deoxygenated. So it's an approximation to an arterial oxygenation saturation. But the problem with these is, with those two wavelengths, the red light can't distinguish, the absorbance can't distinguish between carbon monoxide being bound to the binding site and oxygen being bound to the binding site. And likewise, it can't distinguish between methemoglobin and reduced hemoglobin. So these pulse oxes are very unlikely to show you the presence of either carbon monoxide poisoning or methemoglobinemia. And so we're going to put the SATs didn't change. In the clinical lab, what they do is they have a machine that has many more than just two wavelengths, and that can distinguish sort of at these other wavelengths between carbon monoxide and oxygen, or between methemoglobin and hemoglobin. But these tickets usually just print out the content of oxygen, the content of, and then the percent of carboxyhemoglobin and methemoglobin that are going on in the blood. And they don't actually print out a SAT for oxygen itself, because they've already printed out the content, which contains all the information that you need to know. So I thought I'd finish with a bonus question, and I'm going to pause after I ask it and let you think just a little bit. How would chronic obstructive pulmonary disease affect a patient's PaO2, CaO2, and SaO2. So what's the first thing you're going to do? You're going to think about P little a O2. And what's that going to be dependent upon? P big AO2, yes, okay? So let's look at P big AO2. Would P big AO2 be altered? Well, perhaps, and the answer is barometric pressure and FiO2 probably are not changed. But if a patient, particularly a chronic obstructive disease patient, is a CO2 retainer, i.e. is hypoventilating, this would decrease P big AO2 and as a consequence decrease P little AO2. So the other thing we have to think about for P little AO2 is what? That's right, the AA difference. So how would the AA difference affect things? It would almost certainly be increased because there'd be an increase in ventilation perfusion mismatching in almost all chronic obstructive pulmonary disease. And so this too would tend to decrease P little AO2. So we have at least one and possibly two things that are going to cause a patient to have a depressed arterial partial pressure of oxygen. So now we look at our two dependent things, content and sat. How are they likely to change in a patient with COPD? And so we draw our oxygen dissociation curve, and when we look at it, what we see is that the principal effect is this decrease we saw in P little AO2, which is going to decrease content because of the decreased P little AO2 and decrease saturation because of a decreased arterial saturation for oxygen. So that's pulmonary blood gases in a nutshell. Thank you for watching.